Dear Pure Urology viewers, good evening, one and all. Today topic is supine PCNL tips and tricks. The speaker is Dr. Nitesh Kumar. Recently, I have been to East Zone midterm live workshop at Ranchi, and he was one of the speaker, and I was very comfortable, happy listening his concepts about supine PCNL, his videos, his clear expression. So immediately I contacted him for this talk. So in fact, I request all the juniors, if you are doing any juniors means relative to me, there is no junior and senior, as your expertise in the corresponding field, it is only by age. So if anybody is expertise in your fields, then please let me know through messenger. We will invite such speakers, then exchange the knowledge through this Pure Urology forum. So introduce about Nitesh. I am very happy that he has done his he will be talking on supine PCNL tips and tricks. Is also my favorite topic, so I can interact with him. He is working as a consultant urologist at Ford Hospital and Sri Kripa Urocare, Patna since 2020. He has done his MCH in urology from Usmania Medical College, Hyderabad. Is actually our prestigious college where I did my MBBS, and MCH course in Usmania is also one of the very competitive college where you can get trained. He is gold medalist in MBBS and MCH. He is council member of Bihar Urology Society since 2022. He has good academic engagements, around 10 publications and several presentations at various and national state forums. He has been a proponent of supine PCNL and has done 10 presentations on his technique and results of supine PCNL. His area of interest, endourology and laparoscopic surgery, and he has developed a new monoplanar enuclear resection technique for monoplanar TURP. We will see in future that also can be shared with us. Nitish, once again, I must I will stop sharing the screen. Wait. Nitish, are you online? Yeah. So over to you, Nitish. I'm audible now?
Yes, sir.
Yeah, over to you. Thank you once again for accepting the invitation to Pure, and I hand over the program to you.
Thank you, sir.
Please proceed. Nitish. Hello. Hello. Calling. Yeah. Nitish, you rejoined? Hello, Nitish. Unmute.
Yeah.
Yeah, please proceed.
Interruption. There was a loss of connection.
No
At the
problem.
outset, to thank Pure Urology and Dr. Chandramohan sir to giving me this opportunity to speak in this prestigious largest Facebook forum.
Yeah, you are not able to unable to microphone. Speak normally only.
No, sir. I'm speaking from a different phone.
Okay.
I'm audible, sir?
Yeah, you are audible and your screen is visible nicely.
Okay, sir. I will continue. To disclaim, I have no conflict of interest, and the flow of presentation will be related to the surgical steps. All the pros, cons, tips, and tricks will be told along with the specific steps. Coming to the patient selection, almost all patients can be placed in supine, whether they are obese, kyphoscoliosis, scoliosis, children's, and all the malrotated horseshoe and ectopic kidneys can also be done easily in supine. All you need is some extra gadget, the help of laparoscopy or ultrasonography in these cases. Coming to the anesthesia, patient has a good cardiopulmonary status. It's safe for both the spinal and general anesthesia. There's no risk of dislodgement of the tubes, and airway and vascular access is available at all times. One of the things, there's a less risk of hyperthermia. You can see in the video, there's no dripping of water on the patient. So the patient is relatively dry and he's not having this position. To start with the position, we start by adjusting the lithotomy stirrups. We adjust
Your
it parallel.
Your video is breaking. Is it okay?
Yes, sir. 1 minute. Video is okay, sir.
Video is okay, but it is coming in cuts.
Yes, sir.
If you can optimize, it is better.
How to optimize, sir?
Before sharing the screen, you have to optimize. Stop sharing the screen. You have the other computer. Now, when you are sharing the screen, left side below, you will get optimize the screen. Before sharing, you will get left side optimize both video and this thing, audio and video. Is it coming?
Before starting broadcast, sir, or before it?
Before starting broadcast, just click the share the screen. Once
Yes,
you
sir.
share the screen, it will come on the left side. It is left side. Optimize the video, it will come.
It's not coming, sir.
Is it Zoom? It's
Yes, sir,
only,
it's Zoom only, sir.
So in the tab, it will not come. So we don't know whether it comes in tab or not. It's okay. Share and go to the video,
Okay,
no
sir.
problem.
Okay, sir.
Share the screen, no problem. It is
Coming to the position.
Wait.
We first start by adjusting the ipsilateral.
Wait. It is sharing the screen.
And we keep it parallel to the flow. And
yeah. Nitish, am I audible?
Coming to the position. Yes, sir, audible, sir.
Okay, go ahead.
Coming to the position, we start by adjusting this stirrup parallel to the flow, and then we bring the patient down and almost to the edge of the table. This is very important to have a free nephroscope maneuverability. We position the contralateral leg on the opposite stirrup, almost in a lithotomy position, and then ipsilateral stirrup can be kept either folded at the knee or it can be kept straight. If it is kept straight, it has the advantage that the lateral bulge is less, and in patients whose bulky female patients, while going from lower to upper pole, it helps. I'll show in the subsequent sections. I prefer to keep the leg folded because it gives us more space to move between the lithotomy to the puncture or PCNL position. So there's a space to move around. Finally, we should bring the patient to the edge of the table and we should check with the hands. Then we keep very small towels, one below the buttock and other below the scapula or the shoulder, so that there's a minimal rotation of the trunk. If there's a more rotation, then there's a problem that there will be overlapping of the stones over the spine at and am I audible, sir?
You are audible, but your video is breaking a lot. Anyway, no problem, because you don't have choice. You might have used the laptop.
Okay, sir. Actually, in iPad, it was running smoothly. I just checked. No issue, sir. Next time I'll bring in a video format.
Okay.
Coming to the position, we keep very small towels or slight one bottle between one below the scapula and one below the buttock, and we keep the patient to the edge of the table. If the patient is more towards that side, this stirrups and this one will hinder in the movement of the nephroscope when we are looking up. And we keep the ipsilateral hand straight onto the side arm, and the ipsilateral hand is kept across the chest so that is lying comfortably. I asked to keep hold his opposite shoulder and nothing else. Or if the patient is in general anesthesia, it can be tugged and tied. 2 to 3 things can happen in position. One is when there's a lean and thin patient. When we keep the patient to the edge of the table, this type of image might come, and this might interfere in your puncture and dilatation techniques. So you have to push the patient more towards opposite side so that the renal area is almost free of the table side bars which are there. A similar case which was doing today. Uh, Earlier during the puncture and dilatation there was not any problem, but during the nephroscopy I had a problem encountered with the table edge, so I had to move the patient more towards the table edge. So minor adjustments are needed sometimes in few cases. uh, this is what happened today. This is what happened. This is the first image in which we can see that stirrup connector is hindering the movement of the nephroscope when we are going up. So what we did, we pulled the patient up and then out of the way, and we can perform our nephroscopy easily. In the third image or the third video, we can see that the table edge is hindering the movement of the scope. So you can see a lot of towels on the bed, and in this image, we have pulled the patient more towards us, and there's a very less amount of towel. So there's no difficulty in moving up. The stone was almost into the anterior calyx, and we have entered in from the posterior calyx. All these things can happen, and you need to do some minor adjustment like pulling a patient up slightly or pulling towards you for nephroscopy. And this is what happened and this was the end result. After the When we started the procedure, the images were visible like this, but when we completed, the image was like this because we have to pull the patient. So these problems can happen, and some tables have very thick sidebars. These can create some problems in supine. So coming to draping, uh, PCNL drapes are available, but sometimes around 700 bucks, and everywhere you will not get it, mostly in freelancing practice. So what I do is keep small plastic, or even if plastic is not available, the rubber sheets below and hang it down onto the bucket. And then I use one towel and keep it like this. This acts as a table shelf for me to keep the instruments and keep the objects, and nothing will fall down on the floor. And it also helps all the water to fall down. You can see in the second video, I have kept a few things, all the dilators and everything which I was using, I kept on it, and it acts as a shelf. You can use it. In the third image, it acts to catch your stone also. So no need of expensive drapes also for supine PCNL. One side this plastic will help, and one side your Macintosh sheet will help. All the water drips down onto the bucket, and you can see the floor is relatively dry. So it's very useful. Uh, One more hack is a water catch. Uh, you can see, just put a small gauge piece onto the nephroscope and all the water will drip down. So no water will run around and follow one of the, mostly it follows this water inlet channel and it falls down on the floor, falls onto you and you get wet. And one more accessory that you need is a set of raincoat and gumboot. So this is the final position and this will help you not to get wet. Sometimes if water leaks, so you'll be happy doing supine PCNL even in winters. Coming to the OT setup, in this, the C-arm, TV trolley and C-arm screen, all are almost in front of you. You do not need to rotate your neck too much. And you can see the instrument tray is also beside you and everything is accessible. The C-arm paddle and the litho paddle both are along one of your foot and under urologist control. There's a less manpower needed. Only person which is needed is one assistant which is standing beside you and one person to change the bottles. And rest, once the position is set up for a monoplanar puncture, no any help is required. So there's a less manpower needed in the OT and there's a less chaos. There's ease of surgeon and safety. You can see it saves time. It takes hardly few seconds, 2 to 3 seconds or maybe 5 to move from a lithotomy position to a puncture position. You use this rocking rotatable chair. It helps me to adjust the distance between me and the patient, which is sometimes needed. And this is a few seconds which is required. And it also maintains a sterile environment. There's no need of re-dripping the patient. Ureteric catheter is always in sterile vicinity. Coming to the radiation, not only the hands during the puncture and dilatation, but also the distance of the surgeon from the table matters. You can see this is Dr. Tanwar performing a prone PCNL. You can see the distance from the C-arm, how close he is standing while puncture and dilatation. And you can see the distance of a supine PCNL surgeon while operating. It's almost a scope distance or a distance of a lithotomy probe from the patient and from the C-arm screen. So there's a less chance of radiation and the surgeon is relatively safer. There's an accessibility of retrograde access also, and it's a blessing to have a guide wire all across from the puncture site to the external meatus, and you have an access, retrograde access whenever you need to. During RGP and initial puncture, the RGP is under control of the surgeon. The ureteric catheter is nearby. You can easily push the contrast and you'll see the contrast. C-arm paddle is also under your control. So contrast extravasation and these things do not happen. During initial puncture also, you can ask for the needle from the assistant, or when the table is nearby, you can just take it. So a self-help is also possible. So are the slides coming, sir? Hello.
Yeah, coming, Nitish.
Yes.
Yeah.
Coming to the monoplanar puncture in supine, you can see that in the first attempt, kidney was not moving much. So we have not.
Can you change the slide? Now slide is not changed. Previous one only coming. Ease of surgeon and safety.
Yes, sir, that's why I was asking. I've changed the slides, sir, but it's
RGP and initial puncture is coming now.
Yeah. So in RGP and initial puncture,
all of the videos are moving.
Yes, sir. It's coming in frames.
Yeah. Yes. There is a delay in the.
Yes, a delay in the picture. I will try to
transmission. No problem. No problem. People can understand, but you might have made through the laptop. No problem. You can understand what you are telling.
Okay, sir. I will try to adjust with the whatever I'm seeing on the picture.
Yeah.
You can see during this first attempt, kidney is not moving much. So it's almost known that we have not entered. In the second attempt, when we are going, we have adjusted the depth and you can see the movement of the kidney. So this is the confirmatory, and you will feel the giveaway feeling. So what I do is after puncture, I keep most of the guide wire inside the system so that
First of all, I want to ask you,
yes, sir.
where did you select the puncture site in the skin?
Puncture site in the skin is selected by seeing the angle towards what I want to go, and I keep a needle or the blade.
Is it posterior to posterior axillary line? Is it posterior to the rib? Is it inferior to the rib? Exactly, if you have shown anatomical point, it might have been better. Where
Okay.
exactly you start this needle tip, because it is monoclonal, you told. You select one puncture site at the skin.
Yes, I will show you.
Yeah.
In this image, we have marked it. We have marked the
Posterior axillary line. I can see that.
we have marked the ribs and we have marked the iliac crest.
Yeah.
So I select all my puncture point behind this posterior axillary line, and then I do not care that much whether I go below the 12th rib or I go above the 12th rib, even I go above the 11th rib, because it doesn't matter. I will show in the subsequent slides. In supine, even supracostal puncture, supra 11 punctures are safe. So I always go behind this.
Yes.
I'll move to the supine biplanar puncture.
Yeah.
In this, RGP was done and CM is rotated on the first instance. I have kept the needle on the skin and I have turned the CM 30 degree towards the head. So the needle was going down. This is the second instance. I have kept the needle below the patient and turned the CM up. The needle is going up. So biplanar is almost feasible. This is the puncture point by marking, and we are going with the experience, first attempt and then second attempt according to the depth, and we have entered inside. Now again we are changing the Siam towards the head, and you can see the colonic shadow also moving. Colonic shadow is almost anterior, and if they are moving below means they are anterior to it. So after that, puncture track dilatation and everything is same.
Sorry, once again, just to pause it. What I wanted to ask is, you told the needle, when it is anterior,
Yes.
if you rotate the CM to the head end,
Yes.
what will happen to the needle?
It will go up, sir. In this case, I think I have rotated downwards, 30 degree towards the leg.
Okay, so you should be careful. For the
Yes.
audience, you choose one which you want.
Yes,
Whether
sir.
you want to rotate the CM head end or foot end, it's up to you.
Yes.
It will move in other direction
Of the
depending
CM.
on the anterior and posterior. You can easily identify by tilting the needle a little bit anterior posterior whether you are reaching towards the target or not. Sorry, Nitish, I'm interfering because I am also doing supine PCNL regularly.
Yes,
Whether
sir.
you move the CM head end or lower end, it is your choice. Movement of the needle, where we move more towards the head end. So if the needle is anterior, it goes down towards the foot end. So whatever you remember, you check by keeping the needle, as he said, in the abdominal wall. Abdominal wall is anterior. Abdominal wall is anterior. So in biplanar, you can easily identify which direction it is moving. So reach the target accordingly. Here, he has kept the needle and the anterior abdominal wall first, and the needle is going down. And he kept needle in the posterior abdominal wall. The needle has gone up. This is when the CM is moved towards the foot end. After that, he assessed his own estimation, and during that time, the calyxes and kidney both are moving away towards the spine very well. That means you are close to the puncture. That time, urine comes clearly. Sorry for the interference. It is only because the video and the method of each person doing is different, I interfered. Please go ahead, Nitish.
Thank you, sir, for the expert comments. USG guided puncture can also be done. Someone was telling that the puncture's accuracy or the calicial puncture is not possible in supine. But once you are doing or you have started doing a USG guided puncture, it adds to your advantage of a puncture. And Chinese people have also come up with a cross table bullseye technique. Hardly anyone has done it. I have never tried, but it is feasible and it can be done. What are the issues in this RGP and initial puncture? The first issue is a rapid contrast washout. It happens when the ureteric catheter is much up across the PUJ. So what we do is keep the ureteric catheter just below the PUJ, and also the head end can be tilted slightly down. So wash out can be reduced. The second issue is hypermobility of the kidney and rotation. You can see while puncturing, there was a hypermobility. On the first attempt, the kidney is rotating. We are onto the calyx. In second attempt, also kidney is rotating. We are not able to puncture. And when we have kept the hands above the abdomen, we can easily go in. So this advantage is of supine PCNL. And sometimes in prone also we'll find this hypermobile kidneys. And in prone position, you do not have an option to put a counter pressure from the abdomen. So it's an advantage also. The most talked about, what about the colon? What about if I puncture it? So do not be afraid of the colon. Just keep a close look and just see how the colonic gas shadow and the PCS and your needle and dilators are moving. If they are moving independent of each other, means you are safe and you are away from the colon. You can proceed with your puncture and dilatation and nephroscopy. In the tract dilatation, there's a ease of self-help. You can see, you can keep the table very close, and with the rotating chair, you can just rock back and forth from the table and the patient. So you do not need to ask the assistant, and especially if you are in roaming practice or a freelance practice, or you are not with your regular assistant, he does not know what to give, what not to give. This is very handy. You can just pick the things which you require, and you can see the assistant is just folding his hands and standing there. So during dilatation, screwing motion is the key. Again, in this video, you can see that a relatively very hypermobile kidney, and we are not able to go inside. So again, a counter pressure from the abdomen is very helpful. I told about the keeping a guide rod length very short. What I've done in my initial period, the guide rod will come up to here. So I have to either stand and do a supine PCNL, or I have to sit very back on the back. So there was a difficulty in tract dilatation. So I cut my guide wire almost into the 60% length. And now that guide wire almost accommodates in between me and the patient. So it's an help. And if you keep a short tail of the guide wire, that will come accommodate in between the drape which I showed you. And then you can easily do all your tract dilatation and exchanges of dilators by yourself. If the tail is very long, you need a help of assistant. It's not that you should not take a help of assistant, just for information that this also can be done.
Very
Again,
this is important point. The Alken rod, you cut it, huh? Alken rod you will cut?
Yes, sir.
With what?
Just I marked with the serrations and this one.
You'll cut with scissor?
No, sir, not scissors. There's a one instrument which can just make an imprint, and that after circular imprint, just break it, sir.
Okay, okay.
Just like nails, the thing which we do with our nails. I forgot the name.
Okay, okay, okay. And you also cut the guide wire also. That's a good point. The,
No, sir.
guide wire 150 centimeters. If it is more, it will slip out also. Not only you have to go back. These are all very two important innovative thinking by you. If you keep a guide the rod, that is Alken rod, and some people can do direct dilatation in supine PCNL like mini per. But if you wanted to do Alken rod, definitely this rod goes behind you and your chair has to adjust or you have to stand. I am standing actually for that purpose. I will try, and please send me the how to cut the Alken rod as well as the guide wires. Even guide wire I have not cut any time.
Guide wire I do not cut, sir. It can be cut, but guide wire can be maximum of the guide wire can be pushed inside the ureters.
But
Or
that is also too much guide wire inside is also sometimes. I will ask you that question. Please proceed.
okay. Sir. So how to start supine and the case selection? So I started with a simple case, pelvic calyceal, a pelvis stone, 2 centimeter, 1.5 centimeter. Then I moved to 2 stones, and then I moved to a lower pole calyceal stone. And then gradually, when I got into confidence, when I was confident I could do it, I got into simple staghorns, and then started with multiple calyceal calculus, and then stones in a bifid system with multiple punctures required, and these type of cases also all anomalies. So start with the simple cases and then move to complicated ones. So if multiple tracts are required, tracts can be made initially also, and then later also it can be made. One trick is, once you have made one a tract, then in supine it's very difficult to not to let the contrast wash out during your RGP for subsequent punctures. So it becomes sometimes very difficult. What I do is put a Foley's catheter, inflate with contrast, 2 to 3 cc contrast. 2 cc is more than enough, and keep the bulb inflated inside. So it acts almost as a complete occluded system, and then we can have a subsequent RGPs and punctures also as and when needed. Coming to the middle calyx, it's the most comfortable calyx in supine PCNL because it gives a very good, without rotation, access to the pelvis. You can clear all the stones from the pelvis, and then this a lower pole stone which was cleared, and this is going to the upper pole. So intrarenal navigation is not difficult for a middle calyceal puncture, contrary to what we see in a prone PCNL, or contrary to what others will say. It's also comfortable for lower calyceal punctures. But one thing you have to know, that there is an angulatory movement of the kidney. Whenever we try to puncture like this, the kidney will either move this side or this side. And sometimes it might be a troublesome, and you might not able to go inside, or a puncture might not succeed. And you might get an awkward angles for working because the patient will lie down like this, and it's very difficult to go inside even the pelvis sometimes. So what you need to do not target this lowermost calyx, target this calyx which is almost facing laterally and more towards you. In supine, there is no much concept of anterior and posterior. Whichever you puncture is fine. Just target the lateral calyx which is facing towards you.
That is also important point. I agree. The most inferior calyx towards the foot end cannot be punctured without making the ipsilateral limb adducted. You have to remove ipsilateral limb from the lithotomy and keep it straight. Then only you can think of calyx facing the this thing. The lower calyx puncture is, I feel, supine PCNL is slightly difficult if it is angulated more towards the foot. What do you say?
Yes, sir.
Yeah. Correct.
The case which I showed today, it was a lower calyceal puncture. What I encountered difficulty was the track direction was like this. So when I was doing a nephroscopy, this stirrup handle was creating a trouble. So I have to pull it up so that my now nephroscopy line is this one. Second problem which I had is this table. And suppose I'm going to the upper calyx from the lower one. So you will have a direction like this. So this leg, if it is adducted, as sir was telling, this will create problems. So what you have to do, you have to remove the stirrups or keep the leg straight. And in those situations where you are planning and you have looked at the RGP that you are entering to the lower calyx, so in those cases, keeping the ipsilateral leg straight instead of bending at the knee, if it leg is kept straight, it will fall in this line. So this will not hamper much.
Yes.
So one more thing, many people will say stone migration to upper pole is very much in supine PCNL. It's true, and with experience you can minimize this. But even if it happens, there are some tricks to prevent or to retrieve those stones without any additional puncture. And if it migrates to upper pole, many are not doing, or many will not be able to do, or are afraid to do upper pole puncture in supine, and that's why they will be afraid. The third case which I was doing, the similar thing happened. I was afraid to go to the upper calyx. I turned the patient. By the time I turned the patient was almost anesthesia effect has gone. So I have to abandon the case. I later on did RIRS for him. So this is the scenario. This stone will fragment will migrate here. Until unless it's in the upper medial one, it's not an issue. You can easily reach there because the lines and angles will permit. But once it loses here, the upper medial calyx, you can see in the picture. Uh, I've gone to the upper medial calyx, but the stone is not visible. So what I did, I rotated the patient like this, and just a few taps here, and now you can see the stone is visible, and I can retrieve it with the basket, bring it again to the pelvis, and then fragment and remove it.
And one more thing is that because of the gravity, if you put water and come out, the same fragment will come back to pelvis also, most of the time.
Yes, sir. Smaller ones will come, sir.
Smaller ones will come. Bigger one, if it is trapped, as you said, if it goes laterally, slightly difficult. Either you have to push over the ribs or tap. It will usually, unless it is a very narrow infundibulum, you can get away easily.
Yes, sir. Coming to the superior calyx and supracostal puncture, I have a series of almost 70 cases now, the superior supracostal punctures. Coming back to the basic anatomy, when we see, this is a reflection of the pleura and this is the reflection of the lung. So when we see the 12th rib, 11th and 10th rib, this is the posterior axillary line, and we are puncturing almost here. So the pleura is almost not hindering or not coming in between, even if we are going above the 11th rib in this our supine PCNLs. Considering the same thing, suppose this was the stone and we would have tried to puncture it in the bullseye technique in prone. The puncture point would have been supra 12th, or with a deep inspiration, subcostal also puncture could be achieved. Suppose a similar puncture, which this line is tracked towards the lateral wall of the chest, and this was the puncture point in the supine. So it's almost above 11th or almost touching the 10th rib. So because the pleura moves up when we go laterally, it's not an issue that pleural injury will be there, or there will be a lot of problems. So a similar point C, which is subcostal, will be almost above 11th rib in your supine puncture. The thing is, you have to target the upper lateral calyx during the supine PCNL puncture for the upper pole, not the medial ones, which is almost slightly posterior, or the medial one, which we puncture during the prone PCNL. And because this is medial, this provides very direct access to all the calyces and the lower pole. But for the supine PCNL, this calyx will not provide any access, or will be difficult access for the lower pole. It's very good access for the ureter, but not for the lower and middle pole. So it's not like that the upper pole gives a very good access to all the calyces as such in prone.
The picture you have shown previously, go back, please.
Yes, sir.
The picture you have seen, the upper lateral calyx picture for
Yes.
all the audience. This is one of the most difficult case for supine PCNL if the stone is most superior calyx. Most superior. Yeah, that is shown. In that case, that can be easily done with RIRS.
Yes.
That can be easily broken into 2 pieces in 1 minute, get into the pelvis, and the same tract can take it out. See, any calyx, a small or medium sized stone is really troubling you. A RIRS surgeon can break it and bring it to convenient position of the supine PCNL. There are positions like most inferior, most superior calyx are not accessible to easily with the supine PCNL. You have shown very good RGP picture in this. Actually, it is very good RGP picture to comment on the supine PCNL puncture. Right.
This is actually CT urogram picture, sir. This is
Correct.
RGP.
Very good. CT urogram picture has come very well.
I can let's see the variety of cases in which superior pole puncture was done. And this there was system bifid system, and I had to do a superior pole puncture for the upper polar stone. This case, the most dilated calyx was the upper one, and all the calyxes were almost filled with the stones. So I had to go in with the upper, and I was able to complete all or clear all the stones with the upper pole puncture also. This is a case of upper pole diverticular stone, very narrow infundibulum. I tried with RIRS, I could not reach in. So I did upper pole puncture and then removed the stone. This was isolated upper pole puncture stone, so can be done. So all type of cases can be done. Just you need a
Hello, Nitish. Hello. These are the different type of calyces. Nitish,
yes, sir. Came back.
yes. Proceed.
Uh, So the next thing, nephroscopy and scope maneuverability. Many proponents of prone will say that scope maneuverability is not good. In a earlier case I have shown that from a middle calyx, I went into the lower calyx, I went into the pelvis, I went to the upper calyx. So going to the ureter and going to the upper pole is not much difficult. The most maneuverable calyx in supine is the middle one. And it's always better to make one more track than having a top. One more issue was during nephroscopy, a PCS is getting collapsed. When we see when the amplas is very close to the skin, it will be collapsed. In a case today, I was doing nephroscopy, the amplas was very close. I will not able to have a bigger picture. Now I have drawn the amplas, and now you can see the space is much more available. So you again, this is the initially when the amplas was kept very close. There was not much space. And now when the amplas is withdrawn, you can see the pelvis calyceal system has been filled up. So if you pull out the amplas,
even in prone and supine, if the amplage is pulled out sometimes out of the kidney also with safety guide wire, maneuverability will increase a lot because you will depend on the kidney parenchyma, and water outflow in supine PCNL also will decrease, and it will quickly give the vision. What do you say?
yes,
Whenever you have difficulty, you withdraw the amplage, but one must be careful that you should not lose the track. But
yes,
going into ureter like the way you are showing is very easy in supine PCNL. Very easy from middle calyx. Up to mid ureter you can go.
yes, sir.
Like this, you can go up to mid ureter. Okay.
Coming to the lithotripsy, in pneumatic lithotripsy, there's a one more problem. You can see I'm sitting slightly on one side because this case was all prepared for something else. That's why the screen is kept on the same side. But there's a difficulty in keeping the lithotripter rod in between you and the patient. It hampers sometimes because it will have an extra 10 to 15 centimeter length will be needed. So what
I
you can do?
I usually stand up during that time. Tell me what is your way.
I just pull back my chair, sir.
Yeah.
This is what I do. This is what I do, sir. I move back and forth with my chair.
Yeah. This is the thing. Then
Uh,
usually I stand up and do, no problem.
There's a feeling that the stones break very slowly because there's an anti-gravity effect, but it's almost not relevant. And the other things I've said. Lithotripsy with laser is a boon, and you do not have to worry about anything. Just keep on breaking the stones. Sometimes few of the stones, especially in mini PCNL, beware that smaller stone fragments will come and get stuck between your scope and the amplas seat. While coming out, always check whether it's coming out smoothly or not, because sometimes we'll be pulling out, we'll be feeling that my scope is coming and will come out with the amplas and you lose the track. So always be aware that whenever you are fragmenting the stone into smaller dust particles, that hold on to your amplas and have a feeling that amplas is not coming out. Spontaneous removal of the fragment is very easy, and most of the times I do not need to use a lithotripter, need to use a grasper. Even in pneumatic lithotripsy, sometimes or rarely I use a grasper, and this makes the speed of the operation faster because changing the instrument takes time. Only one thing in DJ stenting, this is how I place in my mini PCNL. If many times it will happen that you ask your assistant to push betadine, inflate something, and sometimes the guide wire is not walking down onto the ureter after you have completed the case, and it sometimes takes almost 15, 20, maybe 30 minutes. After then you feel frustrated, okay, no, flip the patient and then we'll put a DJ stent again. It takes again time. All the OT staffs are tired, you are also tired. In this supine PCNL, if DJ stenting is not going in 1 or 2 attempts, just move back to your lithotomy position, place a stent, confirm it with this. And sometimes there will be some bends or strictures also which will prevent the stent from going in. So what you can do, you can pass the guide wire, retrieve it from the from the PCNL site, and then keep the guide wire taut, and anything can be threaded with that. In the exit strategy, I did not see such beautiful calicial cupping pictures when I was doing prone PCNL, but once I shifted to supine, I could see a perfect calicial cup while coming out. And you can also see all the layers. You can also watch for the colon if it is there or not. You can see a very beautiful calicial cup while coming out. If you are afraid of the colon, keep a guide wire and do a antigrade pilogram. Seen Chandramohan sir doing it in all cases. I do not do it regularly, but in doubt, I do it. Simple stapler is enough, or maybe few stitches. Bone which is available with RI, with the advent of RIRS, and this led to many of the surgeons to take up supine PCNL, because in this you can see there were 1, 2, 3, 4 stones. I made one puncture and then retrieved everything with flexible nephroscope, and the case was done. This was a redo case. I could not complete all the stones in the first instance, and this is also a redo case. Multiple stones in all the calyces, all were brought down in front of the nephroscope and done. I'm a solo surgeon, but even in these circumstances, you can just rock back and forth from the lithotomy position. You can hold your scope and then come back. Again, you can operate from the PCNL side. Just in cases of large stone burdens only, you need a simultaneous surgeons. Or
Correct,
if
correct. I agree with this.
very
Same
good.
surgeon with just exchange the camera, and then,
Yes.
or if it is the only outlet, you exchange and then go down and get back all the stones into the pelvis and exchange the camera with nephroscope and take it out and then go here and there is quite
Now
possible.
the disposable ones, small console is available. So in this video, get 2 screens simultaneously. So both can be done and can be seen.
Yes.
Sometimes ureter is not that much accommodative, and you can use your flexible nephroscope or the ureteroscope from the PCNL tract also. This am plus in position and I am retrieving the stones from below. And then again, I will come back and do it. One more very important point of supine PCNL is sometimes for this type of operatory calculus, what we do, we push the stone up and then we flip the patient, what we used to do, and flip the patient and then we start our RGP and puncture. After puncture, we have found that the stone has slipped back again here, and in prone, it's very difficult to reach this level or sometimes mid-ureters. So if this happens, we can easily again push the stone back from the ureter in supine. This is a luxury. You do not have to flip the patient back and forth. Sometimes some errors which were made in our training days, that the stone was here, we have put the catheter here and flip the patient. Again, there's a chaos in the OT. Again, flipping and non-flipping of the patient. So these things are advantage with the supine PCNL. One more thing, RIRS facility is not available. You are pushing this stone. Sometimes this stone goes and lodges up into the middle anterior calyx. The middle anterior calyx is a very short calyx and very medial one. And if the small stone lodges there, ureteric stone, which we are doing a pushback PCNL, and most of the time these stones won't be that much radio opaque and visible on the C-arm. So it's very difficult to have catch hold of those stones. So what I do in my practice, I put a ureteric catheter, do a RGP, place my track, place the amplas in the ureter, and then if it's accessible from there, well and good. If not, then I will push the stone. So stones will not go and lodge into an unfavorable calyx, which is difficult to puncture, and stones are not difficult to find.
Very true.
Last two slides from my perspective, why urologists are not shifting from prone to supine. I would like to quote Albert Einstein and his two theories. There's a first law of motion, that an object at rest will remain at rest unless until a force is acted upon it. So these laws applies to the resident. If the force from the faculty or from the those who are training are not there to teach them supine PCNL, they will remain in rest. That's the inertia of rest to learn the supine PCNL. The next thing is with the consultant, they have inertia of motion, means that they will continue doing prone PCNL unless they get motivated by the ECIRS or IRS or something else. They will continue to do a supine PCNL. So my concluding statement will be a supine PCNL can be a non-stop solution. So what you have to do, you have to master the gradual descent in prone and then only shift to supine. Start slowly, simple cases, and then upscale. All that you need is a leap of faith and you can do it. Thank you, sir.
So let us interact honestly, because I will stop your sharing screen.
Yes.
See, when you are arguing that supine is better, first 1 year, 2 years, I used to say yes, but I have certain reservations where prone is also better.
Yes.
Let us discuss openly. I will debate against supine PCNL with you,
Okay.
and then we will see what we can do. Now, number one question, if by chance, if you don't have RIRS,
Yes.
you don't have RIRS, you are doing a staghorn calculus. So do you think staghorn means not like a large stone in the pelvis? A lot of people think a large stone in the pelvis is difficult. No. Staghorn means at least 3-4 extensions into different calyces with different angles, where you cannot go from one to other.
Yes.
In that case, I feel prone PCNL is easy because the removing of the large fragments and breaking with pneumatic lithotripter is very easy with prone when compared to supine, when the volume is very large. And the vision is very good in prone when you are breaking it. This is my observation. Now I do prone and supine. 1 year back, 3 years I have done only supine. 11, 12 years I have done only prone. Now I choose wisely what I want. So in large staghorn calculus with multiple calyceal stones, complex anatomy, I prefer for 3 reasons prone. One is my dilatation is easy. My vision during the stone breaking is easy because I don't need too much of water. 3, my removal of large fragments is easy because they will stay and you can see and hold and pick it up. How do you defend it?
Calculus, I thought previously that I will shift to prone, but it takes me a lot of trouble to flip the patient, and my OTs is almost running. 3 OTs are running, and I do not get that much staff in my corporate, and even outside also I do not get that much staff. So I get accustomed to doing it in supine. What I face in staghorn cases that I do not try to break it in bigger pieces. It's like a sanding technique. I will show it sometimes. I just keep on hitting the stone, and unless it breaks into smaller fragments, and with the push of water it just keeps coming out. So there's not much trouble for me for doing a staghorn, and I can do
it will take a little more time if you do that, and
yes.
your powder, your small fragments are sometimes annoying in supine in PCNL when you are doing a large volume, because taking out one big piece creates a space so that your vision is very good in prone. That is my point. I'm 95% of my cases are supine, I am telling you, but those 5% of the cases where prone is useful, I wanted to discuss for the audience sake, not to just go against supine PCNL. Yeah. So you told that you wanted to make smaller fragment, they will come out by themselves with water, so there is no difference. Number 2 question. If RIRS is not there, you have struck with the migrated stone in the superior calyx. You don't have an RIRS. Your ureter is tight. You attempted primary PCNL. One lower pole you attempted. The stone has migrated to the lateral calyx of the superior.
Yes.
Most of the times, prone, people say that you can easily puncture without any fear of pleura.
Yes.
Most of the people think that in supine PCNL, the tilt you give, 20-30 degrees tilt you give, it is not sufficient for accessing the stone supracostally. Is it correct or not?
No, so I go into the same line. The line of the first puncture, second and third puncture almost remains same. Maybe a 5 millimeter difference as I go up, because the kidneys are tilted posteriorly. So the upper punctures will be slightly posterior. And even if it migrates to the upper pole, many times I had to puncture it initially, and whenever the stones do not come in, and sometimes in large volume pelvic stone, you keep on fragmenting, and at the last you see that much of the fragment has gone into the upper lateral calyx and has lost there, and creating almost a coagulum with a big fragment. So in those situations, I will directly go to puncture that lateral calyx and will do it. I do not tilt. Earlier I was trying that upper pole puncture, slightly more tilt should be there, but as my experience increased, I do not tilt the patient. The position is same for all the punctures, even made with upper pole or the supracostal supra 11th.
So I will share my opinion in that, because this is a very common question asked during our 4th Saturday workshops also. See, when you don't see the paraspinal region, surgeon will be less comfortable to put needle above the 10th, above the 11th rib. So in supine PCNL, the puncture is horizontal. It is not angulated. As Nitish told, most of the times 15 degrees tilt, provided you are at the edge of the table and the bolster has not slipped out, you will be very easily access that calyx, no problem. If you have doubt, make the bolster go more towards the medial region scapula so that it elevate. you don't shift the entire patient. Only the rotation of the body will be little more to see properly angle of the rib with the spine. If you don't see that, you will not be comfortable. What he said is all supracostal punctures can be done with normal supine positional position is correct, provided you need some experience more than prone. You need little more experience than prone, but the added advantage is from the lower calyx, most of the stones can be retrieved easily from the upper calyx. That means lower calyxal puncture, if it's proper, it can go to the upper calyx and take out all these stones. Like in prone, upper calyxal puncture can take out all the stones lower. It is opposite in supine. So it's a blessing in disguise that if any stone is there in the upper, you can take it out. In fact, we push the stone into the upper calyx, break it and take it out. No problem. In difficult situations, between the 10th and 11th and 11th and 12th puncture is not that difficult. Tilt is not that much required. Reason being, it's a horizontal puncture. You can easily see the lateral aspect of the desired puncture site. You can easily see it. Even with ultrasound or without ultrasound, you can easily see it. More lateral you go, more safer in the supine PCNL puncture. A bit 1 centimeter tract length may be more, but it is of no consequence as far as the supracostal puncture is concerned. Now, my third question. Diverticular stone which is situated medially in the upper calyx. Very tricky situation I am asking, because prone PCNL surgeon says some situations prone is the only answer. Can you tell no situation supine can not handle? Many people want to say if prone can do all the cases, why supine? If ECRS is said, if ECRS is included, prone people will have to step down, definitely. Because if you have 5 stones in 5 calyces, what prone PCNL person can do? Cannot do anything except 5 punctures and flush technique. But I am asking you, if a diverticular stone is present, medial side superior calyx, just at the hilar region, how do you approach that in supine?
2 things I will do, sir. I will prepare my puncture so that I could go slightly medially. The rotation of the trunk will be slightly more in that case. And I will try a full deep inspiration. And I will try to angulate my puncture so that it hits on the top of the kidney. It's not the upper lateral calyx, the medial one. So I would like to come from here. In a video which I was showing that I was operating from the upper calyx, and the direction was almost from above below. That was the upper calyx medial diverticular stone. So it can be done.
For this, my answer is it can be done. But I must tell you, if you travel anything from the lateral angle, there is a chance of injury to the vessel in supine. Whereas in prone, we use bull's eye straight onto the top of the stone from the posterior surface on top. Even in C-arm, sometimes it is difficult to go bullseye, Alkenrod, but needle can be put vertically on the stone, hit on the stone, feel the stone, pass the guide wire, then pass the dilator, and then go on to stone and remove is a little safer than coming laterally, because coming laterally means traveling a little more parenchyma. In the medial aspect, prone has advantage provided the RIRS flexible scope does not reach the stone. But if RIRS scope reaches, again, you are too good an advantage position to take it out without puncture. This is my observation, that slightly prone has advantage if a large medial which is close to the hilum.
Yes.
Now, one more difficult situation I will ask you. Most inferior calyx parallel to the ureter,
Yes.
very close to the ureter. How do you remove it? You told that most inferior calyx cannot be removed. RIRS scope is not going into the inferior calyx, and you are using the needle to puncture the most inferior calyx. So how do you approach most inferior calyx 1 centimeter stone not accessible to RIRS?
Two things can be done, sir. If the stone is large, means I would directly go to the stone. I would directly go to puncture that stone containing calyx. And many times, if they are small stones, I do not go there. I go from the middle calyx, and I can easily reach to that lower pole containing stone, bring it out in the pelvis, or break it into 2 or 3 pieces, and then bring it out the pelvis, powder it, or break it into smaller fragments, and then take it out.
Yeah, your answer is correct, but my version I will tell you. If
Yes.
a large stone more than 1.5 centimeter is situated very deep calyx close to the ureter, in prone PCNL, from back side, just above the iliac crest oblique tract, you can go and hit it inferiorly, which is safer.
Yes.
Whereas we do in supine, lateral part of the stone somehow you have to hit, dilate and go, which is difficult. 100% it is difficult, because the prone position, iliac crest will not come in the puncture because you are vertically down.
Yes.
Whereas in supine PCNL, the lateralmost part of the iliac crest will come in a huge way, even if the leg is adducted. In that case, you have to puncture through the thigh and reach the stone. In the mid thigh, through the thigh fat, you have to go and reach. That will be a large length, and your orientation of the needle to reach that inferior pole is difficult in the supine PCNL. These are my questions, not to debate here. Lot of people say, why should I learn supine PCNL? That's why I'm discussing. Last question. When will you do RIRS in residual stones after supine PCNL? Will you do it immediately in the postoperative day 3, or will you do after 1 month removing the nephrostomy?
In residual stones, my concept is, if you cannot clear with that track, there is no need to leave a nephrostomy there, because it's hardly in the first track. If you cannot access the stone, it's not going to help you in subsequent track. So I remove the nephrostomy, and earliest I have gone in is 7 days because of some issues. But usually I want to go in after at least 14 days, or if a patient is not in a hurry, maximum comfortable is the comfortable time for me is 1 month.
I also feel that re-look in the absence of nephrostomy tract where there is a hole. Better don't go early, because extravasation can occur, especially if the renal parenchyma is not thick. So better go with the flexible scope after 1 month, nothing going to harm, and then do powder, because by the time stent related dilatation of the ureter will be very good, water will be coming out very nicely, chances of fever is less, a little large volume burden also can be done. So with this, I also want to not ask question, at which point of time, why you have learned supine PCNL? Why and who made you to learn?
Actually, it was there. I was attending your conferences and AI new conferences in Hyderabad, and the new thing was supine PCNL everywhere. So we thought we would start doing supine. I did around 3 to 4 cases during my residency days. That at the point when I reached around 200 cases, I thought, okay, I've had enough with supine PCNL. Prone PCNL, I went on asking my seniors, sir, this case will try supine. He said, no, not this case. Case with a more dilatation, we'll do it. And finally, a day came, the hugely dilated kidney, you throw it anywhere, I'll go inside. It was a case like that. And then we went in and could finish the case in supine. Subsequent with one successful case, we were given free hand that you can go in with supine if the cases are simple. So we selected 3 or 4 cases. I, along with my colleague Dr. Karthik and others also, we started doing supine almost during our completion of MCS days. 2 cases were done by my senior, Dr. Vivek, and that also had given us an impetus that we could start the technique. And all thanks to you, sir, and Dr. Aditya Sharma, who has been to ANU and your center, and we kept on seeing these cases that gave us the stimulus.
Okay, thank you very much. So for the audience, if you learn a new technique, there is nothing wrong. If it is useful in certain conditions, it is useful. So I also felt when I attended other conferences like in Trichy, so I thought it is useful. And I thought because I was doing RIRS large volume stones, supine PCNL added to me. After that, I enjoyed both ECIRS. Even today, I say that if there is role of ECIRS is there, supine PCNL is very good. If there is no role of ECIRS, prone and supine, no difference. In large staghorn stones, slightly prone PCNL, I feel better. In very superior calyx stone or very inferior, deep inferior calycial stones, I feel prone is little better. Superior medial diverticular stent, I feel prone is little better. Rest of all the cases, 99% of the cases we are doing supine PCNL. If you learn a new technique, there is nothing wrong, and it is not the debate. It is an additional armamentarium in your technical skills, which may help the patients. Thank you, Nitish. At an earlier age, actually today a little bit hiccup was there on the slides, but your crispness in presentation, understanding of this anatomy and hiccups will help you go a long way. And I wish you all the best. Thank you.